as pediatricians, we can day-to-day practice, headache is a very reasonably common problem, both in young age group and more so common in the adolescent age group. So the etiologies are very varied, and our clinical approach has to be as simplified as possible. But we'll go through as a clinician when you're facing some of the key cases where actually you learn some principles for life. So you may not have to actually go through each and every this one in detail, but some key things which is going to be extremely useful for lifelong learning and put it into practice. So we'll go through a few of the examples for that. And so you have to, as any part of the clinical sciences, so you need to have a detailed history and examination in any child who comes with headache. Make sure you screen for red flags. That is the most important thing. Although it's very small part of the headache syndromes that you have red flag signs, but as a pediatrician, you are worried about missing that, because that's one thing you don't want to do, missing a red flag sign. So you need to list out all the red flag signs, speak to the parents and the child if possible, if the child is interactive. And then if I will probably, if the connection is unstable, I might mute my video, sir. So headache, if it is there are no red flag signs, you are looking for headaches, something like migrainous headaches, tension type headaches, those kind of things, or chronic daily headaches. If you have red flag signs, the second go in for the diagnostic testings. So in pediatric age group, problems history depends on the age of the child. A child of 5 years or 3 years may not be able to express the headache in the same way as an older child can express. And if the child has learning difficulties, it becomes all the more difficult. So they will not be able to express. A child with autism, if he has a brain tumor, all you will get is it just gets excessively irritable. You will not be able to express that he has headache. He might bang his head more. He might become more irritable. So all those things actually makes a diagnosis of headache in these situations very difficult. And also the examination depends on the cooperation of the child. Especially as a pediatrician, we are not tuned to do the fundoscope. So you need to have a good pediatric ophthalmologist as part of your team, who you can have a confidence that, okay, once I refer, that is safely taken care of. We need to have a pathway for when to image or perform a lumbar puncture, and what medications to choose in acute setting versus a prophylactic medications. For a pediatrician and for a clinician as such, anybody is be it a neurologist or anybody, if it can do it into a simplistic classification of whether it is a serious cause for headache or not so serious cause for headache. I think if we have that dichotomy, it becomes easier for on day-to-day basis for us to manage. So history, one of the important thing is when they come with why are you consulting now is a good because if there is a history of headache and they are coming now, what triggered them to come? So is it that recently there was an increased frequency or change in the nature of the headache, or the school absenteeism started last 1 month, that's why they wanted a solution for the headache? So that is a very good handle for us. Why are you consulting now if the problem was there for 2 years? Or they tried medications, failed. So all those things will be useful. Time of onset. So if it is a early morning headaches, all of us are worried. When the child wakes up with a headache, vomitings, there is a raised ICT sign. Duration of the headaches. So many of the time, it's just a very brief duration, and the child may not actually complain of continuous headaches. The child will be playing, a 6-year-old child is just playing. In between the play, comes for a few seconds and say, Mom, I have headache. And then he runs away. So these are probably not very serious causes of headache. But early morning headaches associated with vomitings and other speech disturbances would be more difficult. Quality of headache. We need to try and stimulate the child to describe in their own words, what do they feel. Whenever the child is more than 5 years, they'll be able to express. You can give some leading terms as to whether it is something like a knife sharp stabbing pain, or a sort of a tight band around the head, and it is one unilateral, bilateral, any particular location, frontal. Those clues can be given, but first ask the child to describe the quality and location of pain and intensity. Intensity is usually associated with how it is impairing the daily routine. So some children say they have very severe pain. When you go into the depth, the parents say the child is always playing fine. Only when for a few minutes he'll say there is a headache, and then but he doesn't stop his activities. But a headache which stops the daily routine of the child, alters the daily routine of the child, that is a significant type of headache, which we need to be careful. So what are the ameliorating factors? What are the aggravating factors? So is there something, if the child actually strains in the stool and has a severe headache at that time and syncope, be very careful about that. So it is a Valsalva maneuver which is triggering of a headache and also sometimes rarely a syncope, which means that you are probably dealing with a raised intracranial pressure. So during Valsalva maneuver, there is a significant increase in intrathoracic pressure. Your venous return is reduced, the intracranial pressure increases, and that causes you to have a significant headache, and it is always a sign of raised intracranial pressure. So that kind of history, if you get by these maneuvers, then be careful about it and investigate. This is a red flag sign. What are the factors that ameliorate? So a calm environment, dark environment, less of having a good sleep helps. Then you are probably dealing with something like migraine. If it is a chronic headache, efficacy of medications taken, what help them will also be a good clue towards what kind of headache they are. If you are taking antihistamines, decongestants, and that is helping, probably it's a sinus headache. And how the quality of life is impaired. Is the child stopping to go to school? So that is an important clue, especially in more than 8 to 13-year-old children. If the child has headache, but is not going to school for 1 or 2 months, you need to start thinking whether it's a non-organic causes of headache, which is also extremely common etiology for long-term headaches. So you can classify them. One is serious headache or non-serious headache. Second one is acute headache, acute recurrent headaches, chronic progressive headaches, and chronic headaches. So that kind of dichotomy will help us to narrow down to the different differential diagnosis. So the common causes like upper respiratory tract infections, acute sinusitis are very common causes of acute headaches in children. So postictal headaches, obviously there will be a history of seizure most of the times. Only if the child had a seizure in the night, nobody noticed it, and the morning they wake up with a headache. So that would be one of the possibilities. Dental caries, high doses of vitamin A and D, which causes idiopathic intracranial hypertension. Or if the child has VP shunt, the malfunction obviously can cause ventricular peritoneal malfunction. Shunt malfunction can cause rise ICT features and headaches. And all of your severe etiologies like brain tumor, hydrocephalus, or hemorrhages can present acute headaches, which is you have to pick up at that time and manage them. If you have acute headaches but coming on repeatedly, then you are looking at causes like migraine, tension type headaches, clustered headaches, hypertension, hyperthyroidism, sometimes rarely medication induced, and MELAS as well. Medication induced is far more common in Western countries, where the adolescents take over-the-counter medications quite frequently for the tension type headaches, and they land up in medication induced headaches as well. But this is one category. Progressive is the one category where you have to be extremely careful about. If the child has a headache, which is progressively increasing in intensity of headache, it is associated with other symptoms, walking difficulty, speech difficulty, behavior is changed. The child has become extremely irritable now. So you are looking at something which is progressive. All of them, as you can see, the brain tumor, hydrocephalus, idiopathic intracranial hypertension, abscess, chronic subdural hematomas is not common in children, but it can be seen in child who already has a diffuse atrophy because of a secondary pathology, and then they present with chronic subdural hematomas. It's very common in elderly. In elderly, actually, they can present with dementia with chronic subdural hematomas. In pediatric age group, most of the hematomas are acute, and you are going to pick up them quite early. So other common, the largest category obviously would be the chronic headaches, which are chronic migraine, chronic tension type headaches, and post-concussive syndromes also can give rise to chronic headaches. So categorizing them into 4 of this and looking at the etiologies, although they are not exclusive, but there are a lot of overlaps, but I think that is a useful outline for us as a clinician to have it as a starting point. So this is a 24-month-old who had presented to us. As you can see, there is a huge midline tumor, contrast enhancing multiloculated midline tumor, which was a pterotorhabdoid tumor with obstructive hydrocephalus. Had a slightly large head as well with AF, which was not fully closed. So what do you think the symptoms of this child would be? So you have a large tumor with obstructive hydrocephalus. And answering the chat box, we use for interactive session. Of course, we can't see. I think this is a clinical situation, not theoretical situations. These are clinical situations what we have faced. This child had irritability for 2 weeks and walking difficulty with right-sided weakness. So if the same thing happens in a 7-year-old, severe headache could be one of the important manifestation. Just because he is young, he cannot express. So here irritability is expression of raised ICT, and otherwise it could have been like a headache. Head circumference was 50th weight was 50th centile, head circumference was disproportionately large. This is another thing as pediatrician, I would request you to always document the first consultation and follow-up consultations, document as a appropriately all the centiles and chart it on the growth charts. So this is a very important clue, even if you have not done a scan. So there is something disproportionately long. Your height and weight are 50th or 15th centile, but your head circumference is 95th centile. Although it is within the normal range, it is significantly higher than the other centiles. So that should actually, that will automatically raise your doubt as to why this head circumference is high in this child. So deep tendon reflexes are brisk bilaterally, and there was early papilledema. Mind you, papilledema is not a common early sign in any of the intracranial tumors. It's a late sign. So absence of papilledema does not rule out a significant intracranial pathology. So our clinical diagnosis was stroke in evaluation to investigate for intracranial space occupying lesion. So the lesson we learned was headache may not be a manifestation even in presence of significant raised ICT in less than 3-year-old or in children who are not able to express themselves expressly. We are seeing the high incidence of autism. They are also prone for all of these kind of pathologies. They are very poorly expressive non-verbal autism. So you need to be very careful. So that's a lesson from that child. We had another 9-year-old girl, first consult for headache in the early morning hours with vomitings. It's obviously a very clear red flag sign. Some squint was noted by parents, very well educated parents. In March, the COVID has already started. Lockdown had already started. So no walking difficulties. What the parents were very apprehensive. They didn't know what COVID meant. They didn't want to go to hospital. The pictures of squint was sent to an ophthalmologist whom they knew. So he said it could be some post-viral weakness, just follow up. The child continued to have some headaches, vomitings. Pediatrician evaluated this child, treated as UTI because there are 8 cells. And then because the headache and vomiting, more predominantly vomiting persisted, upper GI contrast was done. Grade 2 reflex was started, anti-reflex medication was started. Mind you, in a 9-year-old, grade 2 reflex causing headache. Headache is odd thing. You can have some vomitings, but not everyday early morning vomitings. Headache should not be there as part of symptom complex of your GERD. So if you have a combination of squint, new onset, especially new onset squint, new onset torticollis, extremely be careful about it. New onset torticollis is a danger sign. So it says that there is a tonsillar herniation. So whenever there is tonsillar herniation, your neck will be tilted to one side. So that is one of the worrisome sign. You have a squint, head tilt, new onset in any child, please take it seriously and investigate. So this child was almost for 2-3 months. In mild reduction, of July, she started having early morning headaches, not able to run, which she was very active. She became dull, and she started getting tired easily. And last 10 days, there are balancing issues as well. And the other thing was she started having tinnitus, which is also seen as part of the severe raised ICT. No papilledema was there. She had a clear right lateral rectus palsy, cerebellar ataxia, and deep tendon reflexes were brisk. So you have a very clear, all the signs were pointing towards intracranial space occupying lesion, but it was because of the COVID situation, things went wrong all the way possible. So she could have been diagnosed at least 3.5 months before. And whatever the reason, the pediatrician continued to treat for GERD. What I would suggest is one complete neurological examination is mandatory. Examination of blood pressure is mandatory. Any child comes with headache, and documenting your examination is also extremely important in this era where litigations are not a far away thing. So this is a scan. As you can see, a large midline posterior fossa tumor with obstructive hydrocephalus. I was treating this tumor for 4 months. So she had the telltale signs of this a significant intracranial going on. This is not taken out from any textbooks or any imagination. This is the child I just saw 2 weeks back from a very well educated family. The COVID has changed the scenario significantly. They are so apprehensive to walk into hospitals. So a lot of these things are happening. So be extremely careful. If you're doing video consults, be extremely careful what you are documenting. So this child underwent resective surgery and we patient as well. So the lesson from that case is a combination of vomitings, headache, squint, or torticollis. Never ignore it as GERD. That might be just a deviation away from the underlying etiology. Always get a combination of ophthalmological examination, low threshold for scan in these sort of situations. There is another child, 7-year-old girl, came with history of headache on standing for last 1 week. So whenever somebody gets a headache on standing, what is your thought process? You should start thinking of it is a low pressure headache. So that is what you usually think of. So we asked for history of head injuries, any CSF leak, otorrhea, rhinorrhea. There was no history of head injuries. Head injuries cause cribriform plate fractures, and that can cause CSF leaks and low pressure headaches. So she had never undergone any CSF lumbar puncture or anything in recent time. So we were not sure why she's having this. Was seen by pediatrician, blood pressure was normal, clinical exam was normal, and they requested a video consult. So we went through all those histories, they were normal, and follow-up examination was suggested if the symptoms did not subside in next 1 week's time. So symptoms were persistent for 10 days, every day always on standing. On examination, child had mild pallor, no lymphadenopathy, organomegaly, and blood pressures were normal. Fundi normal, normal extraocular movements, and gait, everything was normal. So because it was persistent headache, the child was not able to sit in the class for a long period. She had to lie down and attend her online classes. So we actually got a MRI brain with venogram. That was completely normal. So what do you do next? So what are the thought process? If you are the clinician seeing this child, what are the other things you would like to think of? So this child taught us a huge lesson for us and changed the investigations, what we would do in this sort of situation. We sent a CBP, ESR, CRP, creatinine to look at the end organ functions. 2 hours later, the lab calls up saying that the hemoglobin is 6.5 grams, WBC is 46,000, platelets are 90,000, and there are abnormal cells on peripheral smear suggestive of acute lymphoblastic leukemia. This is just 1.5 months back we had this child. So the anemia was causing the headache on when she stands up suddenly. She used to have a low pressure kind of headaches because of this severe anemia. Probably it has developed quite rapidly. When they develop slowly, you don't develop those kind of symptoms. If it is rapidly developed, then you start having these kind of symptoms. She didn't have any cutaneous markers, no petechial bleeds, no lymphadenopathy, nothing. And she is on treatment for last one, after the diagnosis immediately next day night, she's on treatment, she is doing well. So any child who complains of headache on standing, ask for history of head trauma, ask for history of CSF rhinorrhea, otorrhea, and if that is not there, do all these markers to look for your hemoglobin levels and see whether you're not missing out on conditions. I'm not saying these are common, but this is extremely important to not to miss these kind of things. So headache on standing, this is your protocol. On upright position, headache in upright position. So this is another quick, this one, although once again uncommon, but emphasizing once again why we need to document our anthropometry. 14-month-old child who came from Mumbai had significant hyperactivity and mild speech delay. Generally, hyperactivity, children are quite active, and hyperactive to the extent to disturb the parents to go to a doctor is extremely unusual in this age group. You had not attained any babbling. His motor abilities were normal. Parents noted a small anterior frontality at birth and which closed at 4 months, which was brought to notice of pediatrician. They said, okay, it can be a variation, but unfortunately there is no documentation of head circumference. So when we saw that head circumference was less than 5th centile, 42 centimeters, no perinatal issues. There was coronal sagittal sutural ridging and with brisk lower limb reflexes, no neurocutaneous markers. Other thing I always want you people to document is any presence of neurocutaneous markers. If you have a TSC markers, if you have Sturge-Weber marker or neurofibromatosis, all of them are associated with various neurological complications, including aneurysms, aneurysmal bleeds, and your tumors, everything. So document for neurocutaneous markers in all children with headaches. Document your anthropometry. And so this child had 42 centimeters. So he had coronal and sutural ridging. So he had primary craniosynostosis with severe intracranial hypertension leading on to that extreme irritability. So all these children, if they can express, they will have severe headaches. So I'm not telling that these children will have headaches, but you should actually pick up these children because they have raised ICT and their manifestations are very limited. So we had an eye evaluation, neurosurgical consultation, and cranioplasty was done with reconstruction. And he is doing well. His speech improved significantly after this, and his irritability reduced phenomenally after the reduction in the raised pressure, the silver beta interference. So microcephaly with sutural ridging, you are looking at primary craniosynostosis.
Dr. Lingesh, another couple of minutes, please. 2 more minutes.
Okay, last 1 or 2 cases, and then I'll see. Yeah. So we have acute headaches. I think I'll just finish probably with acute headaches because that is what we are going to be worried about. Long after training, I received a call from my junior colleague from NIMHANS to thank me for scolding her for not checking a blood pressure in a child with headache. She called because she picked up a 18-year-old with recurrent headaches with significant increase in last 15 days at normal neurology. Blood pressure was now more than 95th centile. This child had renal hypertension. Blood pressure was to reach hypertension. So always measure blood pressure in all children coming with headaches. So red flag signs, systemic symptoms, if they are there, secondary risk factors, fever, weight loss or weight gain, thrombotic risk factors, any history of confusion or drowsiness of any duration, first or worst severe headache, sudden onset headaches, and previous headache history is there, but there is a significant in features. Those things you need to be considering significant. This is a quick, this one, the child with acute headache for 6 days, bifrontal, referred to right eye. It was intermittent and disabling, hospital admission. Dental examination was normal, fundi was normal, and normal neurology, no meningeal signs. MRI brain was reported as normal. But when it was carefully looked at, this child had bad ethmoidal sinusitis. So you need to look at, when you order a neuroimaging, look at structures around the bone as well, because brain as such is a pain, it is not a pain sensitive structure. It is a structure around the brain, the cells, the coverings which give rise to pain. So sinus headaches can be a frequent cause of headaches. You need to be looking at those things. So this is one last case, last but one, 11-year-old 4-month girl who presented with headache last 15 days, onset while doing exercise, online exercise classes were there in March 2020. And father was stuck in another state due to corona. Online classes were adding to stress, which was something completely new. She had occasional vomiting, no nocturnal headaches, no walking difficulties, no fever, recent weight loss. So in a significant change in environment, so we thought there could be psychological factors because father is not there. She was very close to father. And then seen team advised antibiotics, paracetamol, antihistamines, some reduction. And on video consult, the child was normal, speech was fluent, extraocular movements on video consultation, and gait was checked. They were normal, documented that, and we reassured them and educated the parents about the danger signs. What are the danger signs? 3 days later, child comes into the clinic with history of double vision. So because we had told all the list of danger signs on the video consult, the parents were very aware. And because there was a double vision, immediately they came and the child had papilledema, MRI with MR venogram showed all features of raised ICT. So, which was suggestive of idiopathic interaction.
Sir, audio. Hello. Yes, sir. Hello. Sir.
Audio is not here, sir.
Oh.
I mean, looks like, yeah, he has just joined, sir.
Yeah, it got disconnected for it.
Yeah.
Is the screen visible, sir?
Yeah.
Hello?
No.
Screen is not visible. Okay.
Just finish, sir. You can just
Yeah,
finish.
I'll finish that. Yeah. So I'll not go through the causes of this one. Absence of other point is rarely papilla. Without papilledema as well, you can have the idiopathic intracranial hypertension. Although it is rare occurrence, it can happen. So that is one thing. And we went to perform a scan whenever there are red flags, clear change in nature of headaches, abnormality of neurological examination. Lumbar puncture in cases of headaches should be done only after neuroimaging. Always measure the opening pressure. Avoid ketamine for sedation when you are doing the opening pressure. There is no role for EEG in evaluation of headache children. Okay, I think I'm not going to discuss the long-term sort of migraine. The most common things what we are going to look at is the reasons for headache where you shouldn't be missing. So something like this, synovenous thrombosis, a child coming with recurrent headaches, you shouldn't be missing a synovenous thrombosis. This is one condition which causes early papilledema in children with very severe headaches. Especially in adolescent girls, if somebody is on oral contraceptives or had dehydration and the things, you might have high risk of synovenous thrombosis. Okay, fine. I think I'll stop here. If I'm running out of time, we can take questions in the. I can answer the questions in the chat box.
Thank you, sir. Thank you, sir. So, Muthukumar, sir. So, Muthukumar, sir, unmute pannu, sir.
Okay.